all three of these presenters today are founding members of Scopes and Shields. And Scopes and Shields, as noted on the website, was created out of our team's shared interest in helping providers in healthcare lift up all patients, including those in law enforcement custody or experiencing incarceration. They're here to talk about the medical grounds topic, dignifying care and supporting the rights of incarcerated patients. Doctors, thank you so much for being with us today. I'll turn it over to you.
So thanks so much for the opportunity to speak with you at the Department of Medicine at Stanford today. We're really excited for this morning's talk. By the end of the hour, we hope you'll be able to identify disparities associated with mass incarceration, describe some specific challenges to patient-centered care for incarcerated patients, recognize the risk of moral injury to clinicians and learners caring for incarcerated patients, and discuss some strategies for bedside advocacy, including resources like the one that we've created called Scopes and Shields. And we want to state from the outset, because it's important to acknowledge that we actually have tremendous respect and admiration for the role of law enforcement. And so this conversation happens in the context of that respect, but also wanting to activate this audience to think about and question practices that we have maybe accepted unquestioningly in the past. So we don't endorse disregarding rules that are in place to help keep healthcare professionals safe, for instance, and we recognize that some patients pose a risk to others, including the healthcare team. And so any discussion that we mention about restraint use or officer presence at the bedside should take place as a multidisciplinary team. I want to start with a case. This is actually the case that got me interested in this as a topic and a focus area. As a first-year fellow, I took sign out on a patient in the intensive care unit with progressive hypercapnic respiratory failure, and we had been told he was proceeding to need intubation. I went into the room, and this was in the pre-dawn hours, and the outside was dark, but his room was the only in the ICU that was lit up. There were two officers there. One was eating a sandwich. The other had the television on, holding the remote control, and the television was facing the officers, not the patient. The patient himself was cachectic. He could hardly lift his head off the pillow. He was shackled to the bed with upper and lower extremity shackles. And through his BiPAP, he was able to communicate to me that no, he did not want to be intubated. And he laboriously wrote out this note for me. I left the room and went to find my attending physician and said, this man wants to be made comfort measures. We're not going to intubate. But he felt distinctly uncomfortable. He was not sure that an incarcerated patient had the right to refuse a life-sustaining intervention. After settling that issue at his request with legal counsel for our hospital, I then took the request to get this man unshackled from his bed during his dying hours up many chains of hierarchy within the prison, ultimately interrupting the Super Bowl of the Super Bowl viewing party of the deputy warden. And that conversation, unfortunately, did not go well. My patient died shackled to his bed just a few hours after the Super Bowl. However, it changed the course of my future. I ended up pursuing a clinical ethics fellowship and ended up in the American Thoracic Society Ethics Committee, where the three of us met. So here's a brief roadmap of what we're hoping to cover. We're going to talk about some background information about mass incarceration, health, and healthcare, and then we'll discuss challenges to patient-centered care, the risk of moral injury associated with caring for incarcerated patients, and strategies for bedside advocacy. You'll notice that throughout the presentation, the three of us try to use person-first language, and this is because we believe that language matters, and that labels like inmate or prisoner foreground the worst moment of a person's life, if indeed they have perpetrated the crime for which they are currently confined. And so we try to refer to people as patients because they are our patients. But if it's necessary to refer to their carceral status, we refer to them as incarcerated patients. So compared to other developed democracies across the world, you probably all know that we confine more people in our country than any other country in the world. And so this is us in the lower right-hand corner. And you can see the trend over the past few decades of exponential growth, starting at a higher baseline and going up through policy changes that were implemented in the 1980s and 1990s around mandatory minimum sentences and 3 strikes laws, to the point that we just have a massive correctional system spread between jails and prisons across the United States. The statistics are staggering. 7 million adults spend time behind bars every year between jail and prison time. And on any given day, that number is estimated to be around 1.7 to 2 million individuals. In 2019, the last year for which data were available about jail admissions, there were 10 million jail admissions. And about 100 million people in the US have a criminal record. The Pew Charitable Trust in 2008, so this is a little bit old, but it's an unbelievable statistic. In 2008, published data indicating that at that moment in time, 1 in 100 adults in the United States was behind bars. And I'm sure it also will not surprise this audience that that is not evenly distributed across the population. And so minoritized racial and ethnic groups experience much higher rates of incarceration, as you can see on this figure that was created by the Prison Policy Initiative. And I'm going to show you another from the sentencing the sentencing project on this slide. So this is a lifetime likelihood of imprisonment for people born in the year 2001. So 1 in 10 men born in 2001 will experience imprisonment. White men, it's 1 in 20, but Black men, 1 in 5, and Latinx men, 1 in 8. So while California as a state is not a nation leader in incarceration, rates of incarceration, if you look at California plotted against other founding NATO nations, NATO members, you can see that California still far outstrips the other founding NATO members. So this is a problem that exists across the United States. We also looked more specifically and zoomed into around a 30-minute drive of Stanford to kind of show you of the approximately 200,000 people who are incarcerated in the state of California, where they are and where they are in your neighborhood, in your backyard. And so around a little over 12,000 of the beds are in your immediate vicinity. I want to spend a minute talking about the health of incarcerated persons. It's important for us to recognize that when you see an incarcerated person, they often will have experienced personally, will have been the victim of violence, childhood trauma. They may have low educational attainment, have experienced substance use, food insecurity, housing insecurity as pre-confinement exposures. And so this also translates to poor healthcare access, pre-confinement, and high chronic disease burden. So these are diseases like asthma, hypertension, obesity, heart disease, HIV, certain cancers. And we also see higher rates than age and race and ethnicity matched peers of mental health and substance use disorders. This came into sharper focus, I think, during the COVID pandemic, where we saw COVID outcomes both early in the pandemic and then in follow-up data later in the pandemic, demonstrating not only much higher rates of infection, COVID infection, which is perhaps not a surprise with congregate living situation and poor access to hygiene materials. So a 5.5 higher rate in this article, but also a 3 times higher mortality standardized to age and sex. And I think this largely reflects this pre-confinement and state of health and the chronic disease burden of this population, who we think of as a medically complex patient population. Unfortunately, data remain quite poor, tracking around minoritized racial and ethnic groups. So they're confined largely to, say, single systems, single correctional system studies, or single healthcare system studies to look. But when these have been examined within these single systems, you find higher rates of chronic diseases and, in one study, higher hospital mortality. These were pre-COVID. And then during COVID, the Texas Department of Corrections, during the first year of the COVID pandemic, there was an article demonstrating a 1.16 times higher rate of mortality for Black incarcerated people compared to their white counterparts, and more than 2 times higher for Hispanic compared to their white counterparts from COVID, attributed to COVID specifically. So the carceral population, the US prison population, is aging and aging rapidly. In fact, this is the fastest growing demographic in the US prison systems overall. So there are over 150,000 older adults behind bars. How you define this is a little bit nebulous depending on the information source, and a lot of prison information sources are setting that bar at 50 or 55. And this is largely because people have such a chronic disease burden that there's earlier onset of diseases and accelerated progression, and a high prevalence of geriatric conditions. One source projects that by 2030, a third of the people in federal prison are projected to be in this 55 plus category, and 1 in 10 federal people in federal prison is currently serving a life sentence. So people are expected to age in place and die within the prison system. So I mentioned geriatric conditions. Think of people aging in place and developing dementia, with traumatic brain injury history, with low educational attainment and substance use history as risk factors for dementia. And think about navigating the carceral setting and climbing up onto a bunk bed and getting back and forth to the mess hall or things like that. There are increasingly specialized units that are just focused on providing care for older adults who are still incarcerated. And this is starting to catch the attention of the media. So these are 2 examples of investigative journalists from reputable sources who have done deep dives into the aging of our US prison population that we highly recommend. So let's talk a little bit about carceral health care. The 8th Amendment to the Constitution prohibits cruel and unusual punishment, and its roots actually go all the way back to Magna Carta. And so there is an established right to healthcare that was further clarified in 1976 with a Supreme Court ruling called Estelle v. Gamble that established a limited right, but a right to receive healthcare. And if someone weren't to receive healthcare, that would constitute negligence on their behalf. But how that healthcare is delivered and where that healthcare delivered varies widely depending on where somebody is confined. So on-site care might range from a nurse being present several days a week to do intake evaluations and occasional presence of a nurse practitioner or a PA or physician, to 24/7 nurse practitioner, physician, and nurse presence in larger facilities. And some facilities, correctional campuses, even have freestanding hospitals, but those are very rare. For the most part, if somebody's healthcare needs exceed the capability of the jail or the prison where they are confined, they will be transported off-site, and that's where people in academic and private practice are likely to interact with them. So say in specialty clinics, in emergency departments, and then on our wards and in our intensive care units. And I'm going to turn it over to David.
All right, thank you very much, Erin. Share my screen here. There we go. So hello to everyone back on the farm. I'm actually currently in Portugal on a family trip. but couldn't resist the opportunity to participate, to give back a little bit to where I did pulmonary and critical care training, and increasingly a long time ago, and was tolerated so very well by folks like Dr. Harmon, Dr. Weinecker, given my interest in medical ethics. And so on that note, let's look at a case that illustrates some of the challenges that are going to arise to the ethical norm of patient-centered care for this population. So this is a gentleman that I encountered once I went to Loma Linda, but I may as well have encountered him when I was rotating down at Valley in Santa Clara, as I imagine a number of you do. The 28-year-old gentleman, he had multiple comorbidities in the setting of being unhoused and actually found frequently in lots around the hospital. So he's brought in by law enforcement for a recurrence of the hyperactive delirium. And law enforcement starts asking the admitting team some interesting questions. Just to isolate a couple of them, they ask, well, Doc, can this guy actually understand if we serve him with notice of charges arising from existing warrants? And by the way, Doc, if he can't, can you just let us know when he's going to be released? Because then presumably he'd be able to understand at that point. We may even take him into custody at that point. So just put yourself in the shoes of that admitting team. Police officers asking you these questions. What do you end up saying to them? Well, while you're thinking about that, let's look at some of the challenges of caring for carceral patients, particularly when they come to your acute care setting. So we know from the literature that one of the challenges is that overall providers actually have decreased engagement. There's a little bit of a step back dealing with these patients, perhaps arising from safety concerns, but also maybe misconceptions about their responsibilities in dealing with these patients, which hopefully we'll help with today. There are numerous privacy violations that represent challenges to caring with these patients, for these patients, and that may in turn be arising from the involvement of law enforcement, as in the case that I just gave you. Now, related to that, one of the challenges for providers can be that there's limited control of the care environment, either actually in the carceral setting, of course, or even in your acute care setting. Now, that in turn can challenge autonomy and lead to impairment of autonomy, both, of course, of the patient, but also of the provider, the ability of the provider to exert their autonomy over the encounter. Now, overall, there may be fewer interventions. It's a specific challenge in dealing with carceral patients, both interventions that we offer and interventions that may be available given the environment of care. Now, one thing there is a lot of is restraint, and specifically shackling, which we'll talk about in just a moment. And that's a challenge caring for these patients. And then last but not least, transitions, particularly to and from the acute care setting, can be really, really poor in terms of the information exchange that would occur relative to, say, when you get a transfer to or from a community hospital. And because of these collected challenges, we can see clinicians kind of deviate from the ethical best practices that they would normally engage in. Now, it's beyond the scope of this talk to go into all of the detail about all of the potential deviations, but we're going to give you an overview of 3 that are particularly significant for this patient population. So first, when we think about the clinical component of restraint use of restraints, you look at our best practice there, it's to avoid using them. That's your default position. You're only going to use the minimum sufficient to ensure safety when there's imminent threat. But we see deviations in the carceral patient population where restraints may be the default in and of themselves. They're all too routine. Similarly, when we look at privacy, we have a default ethical practice that we should be engaging in there, and that is respecting the autonomy and dignity of the patient by, for example, deferring to them when it comes to who should be involved in a care encounter. But we see clinicians will deviate from that, most commonly by involving law enforcement in the encounter, whether or not they truly have to be involved in the particular encounter. And then the last challenge that we're going to illustrate for you is the challenge of engaging in shared decision making. Now, of course, there's the challenge of engaging in decision making with the patient, him or herself, but commonly the real challenge is actually engaging in appropriate surrogate decision making. And all too often, the deviation there is that while normally we would interact with the ethically appropriate surrogate decision maker in a substituted judgment fashion, and with these patients, we may be, perhaps due to legal concerns, involving others in the process who shouldn't be involved in the process. So let's dive into the use of restraints. Again, let's start with a case. And so this is a case described in the medical literature. 26-year-old presented with a mental health emergency and was found to have outstanding warrants, and so was placed in shackles for multiple days. And on day 2, just a warning, it's not going to be pretty, we see this at the wrist. Now, this is described in the charting as a stage 2 pressure ulcer at the shackling site, and it's actually known as, in the medical literature, shackling ulcer. So this is a clear graphic example of an active harm that will occur connected with shackling. But there are both active and passive harms that can arise just from misconceptions on the part of clinicians about shackling. So let's look at some of those. First and foremost, we may think, oh no, we unshackle patients, but it actually turns out that we don't. And similarly, we may think, oh, well, we ask for them to be taken off, but we actually don't. Now, a little bit more nuanced. We may think that we can't ask because, oh, if the shackles are taken off at our request and something bad happens, well, then that will give rise to liability. But duty, right, is a necessary prerequisite for liability, and security is not our duty, it's the duty of the law enforcement officers. Similarly, misconception may take the form of us thinking, oh, well, this is part of keeping us safe and others safe from these violent offenders. That's why they're in shackles in the first place. But it turns out, well, no, the vast majority of the patients that you're going to see as carceral patients, they're not violent offenders. The shackles may be there just from a perception that they need to have elopement prevented. And so it's not a violence thing per se, just because they are in shackles. And then the last misconception, and we really want to hit this one hard, the idea on the part of the clinician that the shackles are just part of the punishment. It's a routine thing to be shackled. And when you think about this situation, really there's 2 aspects that tell you, no, that is an actual misconception. One is, well, the patient in front of you may actually not have been convicted of anything yet. And so then there's actually not a punishment to be levied. That aside, when you think about people who have been convicted, shackling isn't a default part of their punishment, including when they're in a setting where they're going to interact with people outside of the carceral system, like when they have to go to court, for example. You think about that setting, you don't see people shackled on a routine basis. So it shouldn't be the default in the healthcare setting. So hopefully we've persuaded you on that, a key misconception that's pertinent to this challenge. Let's move on to the challenge of maintaining patient privacy when you're dealing with a carceral patient. So of course, in the carceral setting, actual facilities, there's not an expectation of privacy. You can be strip searched on the way in. You can be invasively searched after you've had a visitor. And so as a result, under the law, there's no reasonable expectation of privacy on the part of your carceral patients when they're in the carceral facility. But what about when they come to your acute care setting? Well, yeah, fine. There may be some limits on their rights relative to non-carceral patients, but they still have rights to privacy and dignity. And part of our duty as advocates for our patients, as we generally are considered to be, is that we're going to try to ensure that their rights are respected. Now, when it comes to their bodily privacy, one of the ways in which you can do that is you can actually ask a law enforcement officer to leave the room, particularly during sensitive examinations. You can say, okay, just in the interest of their bodily privacy, as long as it is a safe situation in your medical judgment, yeah, I'd like the law enforcement officer to leave the room. And so you can preserve their bodily privacy that way, and perhaps their informational privacy as well. So looking at that in a little bit more detail, of course, our friend HIPAA comes up when we talk about informational privacy, the protection of certain healthcare information, and that's a duty that rests with covered entities under HIPAA. Now, important note, law enforcement is not a covered entity under HIPAA, so they are not going to have that same duty to preserve the privacy of your carceral patient. But you are a covered entity. And so your default position has to be, no, I'm not going to share information about this patient, including with law enforcement, unless the circumstances of the request for information fall under a specific exception. You see some of them there. I'm sure we're familiar with a lot of them, like if there's an act of crime that law enforcement is looking into. Now, HIPAA, of course, is federal law, and we do need to be cognizant of how that translates to the state experience. And so looking at the great state of California and looking at the laws and regulations that would be pertinent to informational privacy of your carceral patient, those laws in California do refer to HIPAA, as so many states do, but it's important to note that HIPAA is considered to be the minimum standard of privacy, that states can always go beyond it. And in a similar fashion, HIPAA maintains a certain degree of access has to be available for patients to their own information, but states can go beyond that in terms of the level of access that has to be maintained. So you really need to know how your state works. And so just to give you some quick examples on that, we'll start with statutory law. And so the California statutes over Department of Corrections and Rehabilitation, they have some interesting little pearls. For example, if there's been a potential exposure to HIV, Hep B, Hep C, not uncommon in the carceral patient population, then there's a provision that allows testing to be done without a right of refusal on the part of the inmate who needs to be tested given the clinical circumstances. But it's interesting to note that that same statute allows an inmate to request that testing if he or she believes that there's been an exposure. Now, this clearly applies in the carceral setting. I will tell you, under case law, it's not as clear how it applies outside the carceral setting, but it's important to note that that's a statutory right that exists in the state of California. I also put a little pearl there about the use of investigation drugs that actually have a protocol for administration. So, there's all sorts of interesting things that California has in its statutory law, but statutory law is very commonly actually implemented by administrative law in the form of regulations. And so, for example, when we look at that California Code of Regulations, it's noted there that while there's a general presumption under HIPAA and state privacy law that you're only going to disclose the minimum information necessary in a given situation, that exception is actually reversed in situations where the carceral system is telling you, the healthcare provider, pertinent information about your carceral patient. Point being, if you, the provider, think, no, they're not giving me all the information I need, there's actually a regulation that says they have to. So again, important to know the pertinent statutory and regulatory law dealing with these patients. In general, when we review all of that and apply it in the form of standards and the best practice concerning patient privacy for the carceral population, what we see is that they have an assumption of bodily privacy in our acute care setting. And the only boundaries of that are safety in our medical judgment. They have a right to informational privacy. And so when you look at how to respect both of those, yeah, you are only going to issue the minimum information necessary to fulfill an exception to privacy statutes, but you can get the maximum amount of information that you need from the carceral system. In conversations with the patient, him or herself, about their care, your default should be, no, I'm not going to have law enforcement involved in those discussions. It is protected information. And ideally, if you were going to have that discussion, you would involve other people in your hospital system who deal on a routine basis with informational disclosures. Bottom line, take-home point here, is that your default should be, I can, and sometimes should, request that law enforcement not be present during certain examinations and during certain conversations. You have the ability to do that as a healthcare provider. So, having addressed that challenge, we'll delve into the last one that I'll discuss with you, which is decision making. Now, I'll use the work of my colleague Erin, who you just heard from, and her group at Mayo had looked at carceral patients who came to the acute care setting over a 10-year period. What we see is that they very commonly come in circumstances clinically that are going to threaten their capacity to be able to engage in shared decision making. Either they're encephalopathic acutely or for some indeterminate period, or perhaps they have a baseline absence of capacity. So you can see where the ability to engage in surrogate decision making becomes particularly important when we think about shared decision making with this patient population. In terms of what decisions need to be made, yes, there may be some procedural consents, but also it's notable how often end-of-life care concerns arose in this population. What's really distressing when you delve into surrogate decision-making that was seen here is that over half of the time, prison employees were involved in surrogate decision-making. Now, fine, as we see on one half of this diagram, sometimes there wasn't a surrogate decision-making available, but the other half of the diagram tells you that surrogates were available because law enforcement was co-consenting or was present at a family meeting with the surrogate. And there's actually not a requirement for that in the state of California. And so as opposed to the ideal, which would be this, where it's just the surrogate that the provider is engaging in surrogate decision-making with, there's an involvement of law enforcement and a strong signal of that is, unfortunately, inappropriate and violates privacy, as we alluded to earlier. So with that, just to show you, as I close here, kind of the best practices relating to surrogate decision-making, you're empowered, as you always are, to identify potential surrogates of your carceral patients via whatever methods you have, whatever information you have, as I show here. Now, one of those, of course, can be the carceral facility itself, and you want to make sure you reach out to them. Our practical tip is that sometimes you have to ask for the watch commander. And you cannot be forbidden in turn by that facility from trying to identify and contact potential surrogates. And indeed, including the 2023 update to California law enforcement is not a potential category of surrogate decision maker. And one reason for that is you can't assume that the law enforcement officer who's there with the patient actually even knows the patient or would know them well enough to know their best interests and be an appropriate surrogate decision maker. So don't fall into that trap. Overall, just remember, surrogate decision making for your carceral patient should be approached in much the same way as any other patient. They're all your patients. So having reviewed some of those challenges, I'm going to turn it over to my colleague Kathleen to talk about some of the consequences of dealing with those challenges in the form of moral injury.
All right. Thank you, David. So I think it's pretty evident that these can be really difficult, thorny subjects to tackle while also supporting our patients and assuring that we are providing the care that feels right to them. And this is really a recipe for moral injury and moral distress. We heard quite a bit about how difficult it might feel to address the use or validity of requests to use restraints that might go against what we otherwise would do for medical patients. But this also can manifest by asking us to run medically unnecessary tests or potentially asking for limitations or expecting limitations for who can visit the patient and support them at the bedside. And there are myriad other circumstances that we might be facing across the country that we really just don't even have a lot of language around how to respond to. And I think leads to a fair amount of uncertainty, anxiety, and insults to our conscience and our goodness, and can also put up a potential adversarial relationship with law enforcement at the bedside. So it's fair to say that it feels like there's a power dynamic, I think, for many of us if we see law enforcement approaching us or asking us to do something. And it can really be hard to know how best to respond and make sure that we're honoring our duties as providers, but also hearing what the legitimate concerns are from law enforcement. But to illustrate the really murky position that someone could be in the bedside is the case of Alex Bubbles. If those are not familiar with her case, she's a Utah nurse who was caring for an unconscious patient about 6 or 7 years ago and was asked to run some additional blood tests. by the law enforcement who was at the bedside. She, though, brought out her institution's policy, indicating that this is not something that she would do routinely, and it wasn't indicated otherwise, and was met with considerable force into the back of a squad car and facing potential charges that were ultimately dropped. And she, in fact, has been celebrated for her commitment and dedication to patients at the bedside. But again, I think this is a pretty cautionary tale of what many of us might be sensing when we see someone there and we're unsure of how to ask to have a little more protections for our patients. And so this moral injury and distress we may face comes when our values are being challenged by something internal or external to something we feel we can do about. This can contribute to things like burnout and people wanting to just leave the field altogether. In the ICU setting, as well as just medicine in general, and I'm sure the subspecialties and surgical groups as well. This also is something that we're likely propagating from mentors to mentees if we're not at least addressing, naming the problem, and trying to come up with strategies to improve upon it in the future. We can see that it's kind of been a group of patients that seems to be othered in a way that is different from other patient populations who are vulnerable. This is identified in part by looking at these survey responses from an institution a few years ago from 2 different places where they were asked about attitudes towards incarcerated patients. What was reported is that about half of respondents said that they never report researching the crimes for the patients they're taking care of, but that it's sort of the norm for people, when they're honest about it, to report feeling fearful when they're taking care of incarcerated patients. They also identified the negative attitudes that they will carry over into the care for their patients due to their carceral status, and also can recognize the decreased empathy that they have for the patients they're caring for. And so overall, we're finding that awareness of a crime and criminal history is something that is contributing to negative attitudes and less empathy. We talked about mentees and early learners also being impacted by this. And that's demonstrated in part by some qualitative work that's in this publication here about attitudes towards people who are in correctional facilities. There are ample illustrations of how this is something that people feel like it's sort of a no fault situation and something that you won't be worrying about repercussions or retribution if you mess something up. As well as there's this further othering of the incarcerated population where it's sort of, with awe in a kind of grotesque way of the type of pathology that we might encounter when caring for someone who's incarcerated. And further, some of the learners were talking about the contradiction that they perceive to continue to deliver evidence-based care and symptom relief, though the state has already decided that that person's going to be executed for some sort of crime that they've committed in the past. There are some positive experiences, though, that learners also identify in caring for patients who are incarcerated. And I think the ordinary nature of the people that they are taking care of and the sort of way that, this could have happened to any of us, and some of it is just, bad luck at times. And so there are ways that it can also be really eye-opening and uplifting for learners to be involved in the care for people who are incarcerated. But the net effect seems to be that learners are identifying a bit of unworthiness. And this stems from lack of positive messaging from medical schools and faculty leadership. They also are identifying the lack of orientation or ethical guidance for how to take care of patients who have experienced incarceration, and talk about some learned behaviors from those who preceded us in terms of not necessarily thinking that the patients are experiencing what they think that they're experiencing, and suspicion that they're malingering in order for secondary gain to be obtained. There's less empathy, as I mentioned before, as well as judgment when people do go and research criminal history for the patients they're caring for. There are additional structural barriers in terms of delays in laboratory testing, imaging, and lower priorities for interventions and procedures. There's a perception of gatekeeping by providers and staff at the carceral facilities, so that they're prescribed Advil and told to just suck it up and wait it out and see what happens, coming in to seek acute care when things are much more serious at that time. And on the other side, when patients are starting to recover but still have pretty high needs, there's a perception that there's a lot of pressure to send someone back to their prison in order to continue to serve their sentence, even if they're not necessarily medically ready yet. So this leaves us with a threat for imbalance between excessive deference to law enforcement or excessive, sort of righteousness of the healthcare providers. And as Erin had brought up earlier, this isn't something that we're seeking to make an either or path, but meant to be a discussion between healthcare providers and law enforcement, keeping our patient in the center. And so we'll close with some ideas for advocacy and resources that we seem to find to be helpful in our day-to-day. As mentioned in the beginning of our introduction, the three of us are part of a group called Scopes and Shields that was born out of an ethics committee from our subspecialty pulmonary group. And we realized a lot of weight we were carrying related to prior care for patients who were involved in law enforcement, and the ways that we just didn't step up and do what we wanted to do, but that so much of that was because we just didn't have the language or confidence to do so. So we started with a sort of perspectives piece, talking about the way that we could start to make those inquiries in a patient-centered and safe way, but wanted to do more and developed this group, Scopes and Shields, aiming to empower healthcare workers to protect and advocate for patients in law enforcement custody. We're largely an educational resource and have tried to divide up the care settings from emergency room to inpatient and outpatient. And we're continuing to learn from the groups we get to present to, such as Stanford and your affiliated hospitals. But some of the themes that frequently come up include the bedside care and protections for privacy, as David was mentioning, as well as restraints, end-of-life care, and code status, just to name a few. We've also had the privilege of meeting a lot of like-minded folks that want to elevate these types of discussions and resources, and have prepared content such as this one-pager ICU, which distills sort of the higher points, more frequently encountered conditions that we've included in our website into this 2 a.m. reference, which is really what we've been seeking to be able to provide. We're also inspired by the group of like-minded folks in the field and have been impressed with the work of the Stop Shackling Patients group out of Massachusetts, who is a group of medical students that, just decided this was something that they couldn't find acceptable and have been able to get this type of approach, this type of policy change to be adopted by many of the hospitals in Massachusetts, and I believe in front of their state legislature as well. But a reminder that a lot of what this doesn't need to necessarily have a complicated flow diagram. A lot of times it could be just as simple as a respectful conversation with law enforcement at the bedside. And this photo reminds us of this. This is Dr. Wes Ely, who's an intensivist at Vanderbilt and another member of our team. And he was caring for a patient in the last few years who was intubated and sedated, but coming in from a local prison, and he was shackled to a bed. And Wes simply had a conversation with law enforcement and was able to have that shackle removed in real time, and without any sort of animosity or sort of threat to any individual's professional obligations. We would be remiss to not mention the additional leaders in justice-involved advocacy and leadership in the U.S. UCSF has a really outstanding program in the ARCH network. I mentioned the Stop Shackling Patients as well. At Yale, we also have the leadership of Emily Wang and the Siege Center, and some really incredible work they've done there. There's also the Health Equity and Access for Law Enforcement Involved Patients, or HELIP, and then a number of other nonprofit advocacy organizations like Families Against Mandatory Minimums. As a group, we're a little over a year old, but have really been just so motivated to continue to do this work and find good partners. We are fortunate for the partnerships we found from our subspecialty group to be able to present to the AMA, and a resolution that was passed last year to develop best practices for acute care in the custody of law enforcement. We continue to look for partnerships and collaborations, And also we're trying to come up with templates for how to do local policy inquiries so that we can develop ways to ask the questions and align with what the sort of commitments are for the institution, but also think of opportunities to improve patient dignity for patients who are justice involved. We also are looking for scholarship opportunities through manuscripts, grants, and society presentations, and are very, very grateful for the opportunity to present at grand rounds, such as at Stanford today. So in conclusion, I hope a few things you take away from this are that person-centered words are a way to elevate your patient and make sure that we're celebrating them as someone who deserves our respect and dignity. Because mass incarceration is something that's faced way too often and propagates a lot of health disparities in the US. We have a lot of challenges to patient-centered care, and David went through at least some of the most frequently encountered ones with shackling, privacy, and medical decision-making. But also, we should be optimistic because when we choose to embrace our professional privilege, we can work to address our patients' unmet needs. We look forward to learning from boots on the ground here and additional local efforts, and also want to acknowledge the hard work of Amin Sergu, Matt Griffith, and Wes Ely for our Scopes and Shields group. So we're happy to take any questions at this time.
Thank you so much for all this great advocacy work, and again, joining us today. I want to get right into it because we already have a lot of questions and not a lot of time. Dr. Berry had mentioned, she referenced Dr. Winslow, who I'm going to ask to speak in a moment. Stanford currently does not accept incarcerated patients. Its subspecialty clinics, oncology is the one specialty which does a telehealth option. Her and Dean Winslow, Dr. Winslow, have advocated for these folks to be seen in consultation. And she also mentions contacting Dr. Mays and David Enmus, our CEO, to advocate for their care. I want to queue up Dr. Winslow is going to comment for a couple minutes about care locally here, put that in context as well, particularly in the Santa Clara Valley. Dr. Winslow, thanks for being with us.
Thank you, Errol. Can you hear me okay?
Yes.
Great. So anyway, I think we are actually very fortunate in Santa Clara County that we have such excellent care that we provide to incarcerated people in our county jails. I think as many of you know, that in most jails and prisons that medical care is actually contracted to basically medical contractors, which vary in quality a lot. And we are so lucky that Santa Clara Valley Medical Center actually has a division of custody health services. It was started about 20 years ago by Dr. Alex Chorney, who actually is also a pulmonary critical care trained doctor. So again, as you know, that Santa Clara Valley Medical Center is one of our 3 teaching hospitals. So our incarcerated people in our 2 county jails really get excellent care. Occasionally, there have been glitches when there's a problem that a patient has that is above and beyond, what Santa Clara Valley can manage. But I've also just been very pleasantly surprised a couple of times when this is brought to my attention. As recently as last week, we've been able to get these patients cared for at Stanford. So again, I think we're very fortunate in our area, and a big shout out to Alex Chorney and Santa Clara Valley. So anyway, I'll be quiet now, Errol, but thank you so much. And I want to thank all 3 panelists for a great presentation today.
Thank you, Dr. Winslow, as always, and thanks for being here. I'm going to hop in, if it's okay, try to get to a number of questions. Dr. Hack asks, what are we allowed to discuss with incarcerated patients? Just talked about a little bit. The paperwork I get from a federal facility states we are not to discuss their medical care.
So I can handle that. You should feel empowered to talk about the medical care of your patient with your patient. There are certain procedural things that you need to bear in mind, like if you were to advise that diagnostic tests were going to occur, giving the location of that test and the date of that test is typically off limits. But aside from that, forecasting that a diagnostic test will be necessary is appropriate, and involving them talking about prognosis, talking about this is their medical information. They have a right to that medical information. And so there shouldn't be any kind of restraint that I can imagine is justifiable in terms of sharing medical information with the patient.
Excellent. Dr. Vasquez asks, many institutions in the United States exclude incarcerated patients from consideration for receiving organ transplantation. Could you comment?
David, go for it.
So there's a lot of comments that we could make. I think the short version is, yeah, it's a thorny issue. There are a lot of considerations, as I'm sure we all know, beyond strictly the medical comorbidities. Yeah, when we evaluate patients for lung transplant, for example, a big part of that is what is their degree of social support. And as was illustrated by the review of all of the disparities affecting this population, the social support can be remarkably and unfortunately lacking. Right. So it may well be that the exclusion, when it does occur, isn't grounded just in their carceral status. You do hope that it's not grounded just in their carceral status, but is a more global view of their candidacy. And if you get a sense that it's not, then again, advocate for it to be that way.
Great. A comment from Dr. Lewin Parkinson, Kate, a medical ethicist, that Kate, I was debating emailing you in the middle of the night to join, but I know we have so many people in discussion. Thank you for your comment here. She states, a much needed discussion. Thank you. We will also add that if an incarcerated patient has the capacity to make their own medical decisions, they should. Law enforcement has tried to deny these patients the right decision making, and we have asked them for a court order, which we have never received. Okay, thanks for your work in this space. I'll keep going through some questions. Dr. Klein, Santa Clara County is considering the use of tasers as a potential method of restraint, although generally considered a less than lethal form of restraint. Several hundreds of deaths have been reported from tasers, especially patients under the influence of drugs. Any thoughts on this?
Yeah, it's hard to imagine that we could come up with medically justifiable use for tasers in clinical care. I think that taking care of an agitated patient is no doubt can be pretty frightening. And then if you see law enforcement at the bedside as well, I'm sure that it would always just start to convey a greater risk for the care team. But I can't imagine a circumstance where I would advocate for that or feel like that's the right thing. And I think, as is pointed out by Dr. Klein, there's considerable risk for using that for patients who are potentially medically unstable further, that's leading to some of that hyperactive state, or may have had some sort of exposures to different substances that might also be leading to that state. And so I would really urge us to find ways to avoid that being part of our armamentarium in the clinical setting.
Do you mind if we go a minute or so over? I have one more question and a comment before we close. Thank you.
Sure.
Dr. Cartwright states, in the past, I have often saw incarcerated patients in consultation with my subspecialty GI clinic at Stanford, which made short and long-term recommendations for their care, often included expensive medications like anti-TNF blockers, which were not followed by local doctors, as I learned when the patients returned for follow-up a year or so later, and minimum, if any, care had been provided in the interim. How do you recommend solving this problem?
It's a really difficult problem. And I do want to acknowledge, because there's also a parallel discussion going on in the chat too, that correctional medicine is really difficult. And so is acute care medicine and clinic medicine in terms of interacting with patients, risk of violence, whether or not the person is incarcerated. We in healthcare face a lot of risk personally. And so I want to acknowledge that as we talk about, there must be a reason that Santa Clara County is thinking about using tasers, and we don't want to minimize risk to healthcare professionals. We're just encouraging people to keep looking for humanistic and sensible solutions. We experience this in the pulmonary clinic as well, where we'll come up with a recommendation, and if the patient ever comes back, none of the recommendations were followed, and how to do this better. These transitions of care are really challenging. I mean, and often we are handwriting out our recommendations, at least here on paper charts. The best that I can say is that I pick up the phone and speak with, and I recognize this takes more time, and we all are pressed for time, but I have found great partnership, whether it's with the State Department of Corrections or the Federal Bureau of Prisons, when I speak with a colleague who is working within correctional medicine, when I explain what I'm looking for. In general, I have found great partnership and advocacy. There are a lot of people who are doing that work because they care deeply and because they want to advocate and uplift these patients. And so I have found that having a conversation can help elevate the agenda. That may be the best that I can say, with a minute left.
I want to end with this comment by Dr. Klein. He says, during my 28 years as medical director of Santa Clara County's Juvenile Hall, 7 Stanford medical students revealed that they had been previously incarcerated. What a wonderful piece of information to help us take care of this population and realize this can happen to anyone. Thank you so much for being here with us. And I mentioned at the beginning, we haven't covered this topic. We actually are covering it again. Dr. Hartman helped schedule one of our faculty members from UCSF to bring this topic in December again. So it's something, thanks to all your advocacy, is something that's more important than I think it's been in the past. That probably speaks a lot to the work that you guys do throughout the nation. So thank you for being here with us today. We'd love to invite you back in the future to come again and chat about this. Thanks everybody for sticking with us, and have a great rest of the day.
Thank you.
Thanks.
Thank you so much.
Enjoy Portugal. Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.